Professor of Medicine at Ohio State University and Director of Interventional Nephrology. He is a President of the American Society of Diagnosis and Interventional Nephrology, and he is going to be addressing preserving arteries and veins for AV access.
Good afternoon, honorable chairpersons and my friends. First of all, I would like to sincerely thank the organizers, Professor Al-Shakabi and Dr. Amara, Dr. Dawood, in fact, for inviting me here. It's really my pleasure, my first time in Egypt, so I hope the pyramids are still there when I go to see them. I know that you have a large population of dialysis patients, and when you want to create a vascular access, you need to have good blood vessels there. What if those have been stolen from you before? So it is extremely important that you pay attention to preserving the blood vessels. You must have heard of the term vein mapping, and vein mapping is probably not the most right term, because you don't want to just save the veins. You want to also save the arteries. So you have to save the whole circuit for the vascular access to be successful. So I'm very quickly going to discuss why it is important to preserve vessels, just like I told you, and discuss the common clinical actions that you can take to preserve blood vessels and all the blood vessels. So in any CKD patient, a chronic kidney disease patient, your goals are mainly three. One is that in early stages you want to diagnose and preserve the renal function as much as you can, and you heard a very nice talk about how to preserve kidney function. Then you need to plan and prepare the patient for dialysis when the time comes that when their kidney function is progressing, and finally once they have lost the kidney function, then you need to start replacement therapy. We know that in those people who have bad kidney function, they are going to progress. This was a 7-year follow-up of 400 patients, and almost 70% of those ended up on dialysis. They required replacement therapy, and of course there is a high mortality in these patients as well. So there were 2 papers in this one issue of New England Journal in 2004 back to back, and one of those was by Dr. Go, 1.1 million patients, as you can see. As the kidney function goes down from greater than 60 to less than 15, their hazard of cardiovascular events increases very significantly. So about 3 times higher risk of death or cardiovascular events in these patients with advanced kidney function. So cardiovascular risk has to be kept in mind, and how you treat that cardiovascular risk is also very important for vessel preservation. So you must have heard of transradial heart catheterization, the percutaneous coronary interventions. So in the past, people used to use femoral artery to go into the coronary vessels and do angioplasty. Now there is more and more trend of using the radial artery, which is great. It's easier for the patient, it looks good, but the problem is if these patients have CKD, what is going to happen if they have the radial artery occlusion or brachial artery occlusion? So you have to be very, very careful. So you can see even though this percentage is less than 1%, but the trend is increasing number of transradial interventions in dialysis and CKD patients as compared to non-CKD and transplant population. So it is also to be kept in mind that about 60% of these people who are getting percutaneous coronary intervention also have advanced CKD, CKD 3B, 4 and 5. So you have to be very careful with their arteries. So now coming to my real topic, how to preserve the vascular access. As you know, there are 3 main vascular accesses that we use. One is arteriovenous fistula, one is arteriovenous graft, and then central venous catheters. And sometimes you need to use some hybrids. So if there is a fistula that has a bad segment, you will need a graft interposition, and we sometimes call it graftula. because it's a graft and fistula combined. And then there is a hero device. I don't know if there is any use in Egypt or not. The hero device is where you connect a graft to the central vein. So essentially you put it in the right atrium like a catheter, but everything is internal. So in patients who have bad central stenosis, you can bypass the catheter. With a catheter, you bypass that central stenosis. All right, so as you know, arteriovenous fistula, you combine an artery and vein, and this vein develops then you can use it for dialysis. This is the best option for you for vascular access, lowest complication rates. It does take 4 to 6 weeks to mature. It has the best long-term patency and requires much less interventions than a graft. Once again, I want to point out again and again that this is a whole entire circuit. Your vascular access is not just in the arm. You have a pump here. I tell my cardiologist friends the heart is only a pump to supply blood vessel to the fistula and the kidneys. So this is the pump. This is the artery going in there. There's the anastomosis. You have the vein, and all with the central veins, it goes back. Any point of time, any place where you have a problem in this circuit, that will cause problem with the vascular access as well. So AV graft, as you know, is a synthetic graft. I know that there is a very small percentage of graft that you use, which is a good thing. You don't need to use it if you have good veins. So generally, if you do not have good veins, you can make the bypass and connect the artery and the vein, so you can have the flow like that. It's ready for use very quickly because it does not need any maturation time other than maybe endothelialization for about 2 weeks or so. But it is not the living thing, so it is more prone to infections, and it tends to clot more also. Your own veins can stay alive with very low flow, but the synthetic tubes cannot do that because they don't have capability to auto-regulate, so they tend to clot more and need more interventions than a fistula. So if you look at the complication rates of dialysis access, AV fistula here has the lowest rate of complications. You can see the infections are less, sepsis is less, need for thrombectomy is less, and angioplasty is less as compared to AV graft. But even the AV graft is a lot better than a catheter in terms of infection because the catheters are really source of infection. I know that just like in United States, in Egypt also, I think most patients start with a catheter and then go on to get a fistula. It will be better to develop a fistula beforehand if you can. And if you look at the expenditure, this is from United States. The patient who has a catheter is the most expensive patient. About $75,000–$80,000 per year is spent on one patient for dialysis with a catheter as compared to graft, which is about $10,000 cheaper, and AV fistula is another $5–10,000 cheaper. So you have less inflammation, you require less EPO, you have less number of infections, your longevity is better. So AV fistula is the most ideal access if you can achieve it. Of course, everybody is not going to achieve, just like Dr. Daud just said. So how do you preserve vessels? There are 3 components of that. One is preserve the peripheral vein, preserve the central vein, and preserve the peripheral arteries. All the 3 components have to be paid attention to, and I will quickly go over all those. So why it is important? Because the vessel preservation is the insurance for the future AV fistula. So it is a lifeline. You have limited sites available to create a vascular access, and as the patient's kidney function is deteriorating, you need to start thinking about vascular access there as well. So what you do is you educate the patient and family way before the dialysis. Very, very important. Otherwise, the patient is going to refuse to get a fistula, and then you will end up with a catheter. So educate the patient and the family. You also have to educate non-nephrologists in the hospital because they also have no clue about the dialysis AV fistula. They don't know how the fistula will be created for dialysis. So you have to train them. Try not to use the veins up in the arm. You should try to use more the dorsum of the hand, and avoid using forearm and antecubital veins for blood draws and infusions. There are a number of sites where you can actually take a look at what things are available. We try to put some bracelets and wristbands in the patients with advanced CKD that do not use these veins. And you can also put bedside warning signs. One other question that keeps on coming is, what do you do with the patient who needs a prolonged IV to give antibiotics for infection, for example? They have osteomyelitis, they need 6 weeks of antibiotics, so people put the PICC lines. And PICC lines are a big time problem. What PICC lines do is, when they are sitting in the small vessels, what is the flow in the upper arm veins, for example? Anybody has any idea what is the how much blood is flowing through a cephalic vein in a normal person? Something about maybe 40-50 ml per minute, not more than that. And then you put a PICC line in there. What is going to happen is that is going to activate the Virchow's triad, and now you are causing stagnation and injury, and it will thrombose. And that vein will be gone for use in dialysis. So considering that, there was a Choosing Wisely campaign in the United States, and American Society of Nephrology said, do not place peripherally inserted catheters. You know the PICC lines what I'm talking about. These are the central veins that go from the arm into the heart and in the SVC, and you use those for infusions. So try not to use those. Those are bad. Instead, you can use a single bore central line which is actually tunneled and which does not cause that much injury. So thrombosis is a very common occurrence in PICC lines. 23% in this study, 38% in this study. So 1/4 to 1/3 of people end up clotting that vein where the PICC line is placed. This is an example. So this patient had a fistula created. They did not know that this patient had a PICC line before. And see, the initial part of fistula developed very well, but look at the remaining part of the cephalic vein. This is all sclerosed and nearly thrombosed. So this access is not going to mature no matter how much angioplasty you do. This is a very long segment. This is going to collapse right away. The second portion is central veins. So eventually all the blood has to go to the heart through via the central veins. So those central veins have to be opened. It is not uncommon to find that those central veins are also stenosed because they had catheters, either temporary catheter or the tunnel catheter. PICC lines could have caused it. It is also very common. Now remember the heart disease in our patients with CKD. So they get pacemakers, they get defibrillators, and the leads travel through those brachiocephalic veins and into the SVC and superior vena cava. They all can get stenosis and thrombosis because of the leads also. So here is a patient. You can see this patient had a fistula placed here, and look at the arm. This is big as such large in comparison to the left side, because the patient has probably a central venous stenosis. So this is not a very good scenario for your patient. It is also very important to know the subclavian lines are more common to cause central venous stenosis as compared to the IJ, and the left-sided lines are not as good as the right side. And I will show you why. So if you look at this catheter was taken out from the right IJ, and you can see there is a smooth one curve. So this catheter was taken out from the right side. Look at on the left side. From the left side, it's not a direct route to the heart. So the vein has at least 3 curves, 2 side by side and 1 anterior posterior. So it is in touch with the vein all the time. And the catheters are not just sitting there. When you move, when your heart beats, when you take a breath, it moves constantly and it causes endothelial damage. When you have endothelial damage, there is a fibrotic reaction and there is thrombosis and platelet plug formation, and eventually that leads to stenosis and thrombosis. I already talked about the PICC line, so I know that there is a short time, so I will not go in detail. I also wanted to point out to you the pacemakers, defibrillators as a cause of central venous stenosis. So this is actually an autopsy. This is actually an MRI, a 3D MRI reconstruction. This is a pacemaker. This is going from the left side. This is one patient. Imagine what is going on here. This is the pacemaker lead. You have a right IJ catheter for dialysis, and you have a left IJ line for the infusions. So there is a traffic jam in the superior vena cava. What is going to happen is this. So superior vena cava is going to get stenosed and thrombosed, and this is a real patient again. Here is leads going, and these are this is a catheter going in the superior vena cava. This is a very common scenario that we see. Again, in this study of 200 patients, there was at 6 months, about 2/3 of the patients had venous lesions already. But in somebody who has only 50 cc's of flow, you are not going to see all that symptom, because the vein is just going to thrombose, but there is not much flow there either. It will go through some other vein. But what happens once you put that patient on dialysis and create a fistula, and there is 1,000 cc's of flow going through that fistula, now suddenly that small road is not enough for the traffic, and the arm starts swelling up. So generally you see these problems in dialysis patients. About 70% of patients became symptomatic with cardiac rhythm devices in this study. So when you are planning access, and if they have a left-sided pacemaker, try to create a fistula on the right side instead of doing on the left. Another way you can do that is the epicardial lead placement. I don't know how common that is here, but what we tell our surgeons, this is a dialysis patient, please do not put the transvenous pacemaker. So the pacemaker actually sits here in the abdomen or on the chest, and then the leads are going actually externally and on the pericardial surface rather than going through the veins. So you can create fistula anywhere. So that is one way you can ask your surgeons. The only problem is that the patient has to stay in the hospital for 1 to 2 days. It's a little more, it's a longer recovery. There are some newer devices which are leadless, so you don't need any leads. 2 devices were approved in US, the Micra and the NanoStim, and those have to be placed again by the cardiologists or the cardiothoracic surgeons, and that will avoid any interruption of the venous supply. There was a publication in 2016 in New England Journal about that as well. So you can see here is the pacemaker, and catheter is still there, which is also not good. But the pacemaker is here, and there is no lead at all. So that would be the best thing. And finally, preservation of the peripheral arteries. So you know, endovascular interventions, as I mentioned to you, those are very common, and people go through the arteries. And the concern is the occlusion of radial artery, which can occur in up to 10% of patients, which is a huge number. And radial artery spasm can occur, and brachial artery stenosis can occur. And the trends are increasing. The transradial interventions are continuing to increase. And again, this is the cumulative incidence of transradial interventions. There was a survey of the cardiologists as to what do you think is going to happen to transradial interventions, and about 50% said it will stay the same, and 50% said it will increase. Very few people said that they will stop doing it. So this is, you have to be very cautious when they are doing trans-arterial interventions. Finally, again, as I mentioned to you, a lot of these people have CKD. 30% have very severe CKD who are undergoing those interventions. To conclude my talk, honorable chairpersons and my colleagues, preserving peripheral vessels is an essential component while planning for dialysis vascular access. You have to implement some strategies. You have to plan not to save not only the peripheral veins but also the central veins. Try not to use the PICC lines. Use a infusion catheter if you have to use. Consider alternative approaches, not utilizing the veins when you need the pacemakers and defibrillators, and try not to use the transradial interventions because, as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. Thank you very much.
Thank you very much, Professor Agrawal, for your excellent presentation. Yes, Dr. Daniel.
Excellent presentation, Dr. Agrawal. I have a question about the hero graft. It's always been a trouble declotting a hero graft, specifically the catheter part. So what's your experience, and how many, also there is a recurrent thrombectomy, like maybe every month. So how can we overcome that, and what's your experience with the clotting of a hero graft?
So once again, I just wanted to point out to you the hero graft is where you have, for example, a graft in the arm, and the central portion is a catheter. So
Try.
So, yeah.
Okay.
Okay. So, so the central portion is clotted. It is a catheter. It is going to clot again and again. Hero grafts are not the best strategy either. Those are for the last, option when you want to create a vascular access in somebody who has a central venous stenosis. So the experience is not going to be good. The catheters cause right atrial thrombus. Yeah, I'm sure you have seen those, and those are very complicated as well. So the best way is to actually just avoid the central venous stenosis. You never need heroes.
So you would not recommend creating the hero and maybe go for a thigh graft because the recurrent thrombectomy and the issues that happen, or you will still go for the hero over creating the thigh graft?
So if you have somebody with good veins in the leg, vein and artery are still intact, I think it is preferable to go for a thigh access rather than go for, yes. Thank you very much.
And now our speaker is Professor Al Hakim. He's a professor of pediatric nephrology and one of the first pioneers who practiced or introduced the field of pediatric